This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. As you can see, our speaker this morning is Dr. Jason So, one of our fourth year fellows. Jason is a member of our clinical investigator track. He's a native Californian, did his undergraduate and medical school studies at University of Southern California, and then did his residency at Cedars-Sinai, did research and clinic under the guidance of Dr. Jonathan Kim, and he is interested in a potential career in sports cardiology, and his topic is in that area today. So without any further ado, Jason So.
Great. Thanks, Dr. Williams. Thanks for giving me the opportunity to talk here. As you said, my clinical and research interest is in sports cardiology. And today I'll actually be talking about the topic that kind of brought me into the area first, trying to answer this question: can one do too much exercise? I'll be talking about some of the cardiovascular controversies in masters endurance athletes. So starting with outline of the talk here, first to kind of define who we're talking about. When we talk about masters athletes, also referred to sometimes as veteran athletes, there's no strict definition here, but generally speaking, we're talking about non-professionals, age 35 to 40 and over. And with regard to what an athlete is, in the field, athletes are generally defined as any individual who places a premium on training, competition, and athletic achievement. So these individuals, while they're not professionals, can perform at a high level and take much of their quality of life around their training, how they perform either in competition or how they perform with their physical goals here. So I'll be discussing three common cases that we see in this population. Now, there are many controversies in sports cardiology, but these are perhaps the most common. And if you see enough athletes, you'll inevitably see these type of patients roll through your general cardiology clinic. Also, I'll tell these in a kind of case-based format. The first one will have coronary calcium. Second one, I'll be discussing atrial fibrillation. And the third, I'll be discussing dilated aorta. And I'll be talking about some exercise associations, clinical implications, and management decisions in these patients. I'll be talking about a lot of studies to kind of tell the story of each of these topics here. Hopefully give you a general overview of each area. So to start, here's case number one. We're looking at an endurance athlete coming in with CAC. So this athlete is a 45-year-old male marathoner. He's been running for 25 years regularly. He runs 40 to 60 miles per week, so that's a good amount of volume. He's got a recent marathon time of 3 hours and 20 minutes, which is a very respectable time in his age group, setting him up in that Boston qualifying range. Now, he doesn't have any symptoms or complaints, but one of his buddies told him about this new cardiac scan you can get to see what your heart looks like. So he ended up getting a commercial coronary calcium scan, and that score, his calcium score was 201, which puts him in the 98th percentile. Now, looking at some of his clinical data, he's got no past medical history. He's not on any medications. On physical exam, he is bradycardic in sinus confirmed by EKG, has a normal healthy blood pressure and a normal healthy BMI. His physical exam is otherwise unremarkable. And looking at his basic lab work, he does not have diabetes, and he's got a relatively healthy LDL of 100. So setting up here with a rhetorical question, which of the following about coronary artery disease in athletes is true? A, regular endurance exercise is associated with increased longevity. B, sudden death during exercise in middle-aged adults is most commonly attributed to atherosclerotic coronary vascular disease. C, endurance exercise is associated with CAC in males and females. Or D, the presence of CAC in athletes does not indicate increased cardiovascular risk. So just kind of keep these answers more in mind as we go through the data here. So first, before we talk about what happens with too much exercise, I don't want to get the wrong picture here. Exercise in general, across almost any study, is a good thing. And in particular, endurance athletes are known to have longevity benefits compared to people who do not exercise. So before we start talking about what happens with too much exercise, just want to clarify here, especially looking at this study here, that endurance exercise is beneficial to longevity. So here we see a French study looking at Tour de France athletes. Once again, that's cyclists who train 30 to 40 hours a week for however long the career is and more, which is at least 10 or 20 years. So this is perhaps the highest volume and intensity endurance athlete you have here. And matching 700 French cyclists to the French male population, we see that these elite athletes have a 41% lower mortality compared to the general population. And look at the key figure here. This applies through the multiple decades of professional cycling. We see that all athletes pretty much age 30 to 85 have increased longevity compared to their less active counterparts. One thing here on the left side, we see this possible increase in mortality in those under 30, but you have to keep in mind that cyclists under 30 have very, very few event rates. So overall, the trend is toward decreased mortality and increased longevity. Now looking back at not elite athletes and looking back at the general population here, this is a study published a few years back in JACC, looking at recreational runners and trying to identify associations between running volume, intensity, and speed, and general and cardiovascular mortality. And here we see, look at these plots on the left. These are people who do not run at all. And going farther rightward, we see different measures of running intensity and frequency. And we see that the main message here is that the more you run, the faster you run, or a combination of that, as long as you're running, you derive significant mortality benefits compared to those who do not run. That's true across whatever definition of whatever category of running you have here. However, if you look kind of just at the general trend, while not statistically significant, we see that this benefit does not seem to increase the more active or the more you run, and that hazard ratio for all-cause mortality kind of just levels off once you almost start doing anything. And particularly if you look at cardiovascular mortality, we see at least a suggestion of what we call, or what's been termed a J-shaped or a U-shaped curve, and that maximum benefit is derived kind of in these lower to moderate ranges of activity. And once you get toward the higher end, there might even be an uptick compared to those who are less active in mortality. But once again, key point here is there's not an increase compared to those who are not active. So speaking of mortality in athletes, here's a study trying to answer what exactly is responsible for people who die suddenly during exercise, and particularly what's responsible for sudden cardiac death in exercisers, not particularly athletes who are at middle age. So this study is performed out of the Oregon Sudden Unexpected Death Study, looking at all the sudden cardiac deaths in the Portland area. So here on this top pie chart, these are the sudden deaths that occurred with exercise in people aged 35 to 65. And the bottom here is sudden death that occurred just overall in that age group as well. And here we see that overwhelmingly sudden death in these groups, whether with or without exercise, is attributed to coronary artery disease, whether or not that's acute disease where some sort of coronary thrombus was identified, or non-acute coronary artery disease where obstructive plaque was otherwise identified. So here overall, the message is that even in exercisers down to as young as 35, the main cause of sudden cardiac death during exercise is garden variety coronary artery disease. Which brings us to looking at coronary disease, specifically coronary calcium, across the different spectrum of activity levels. So here, another study similar to the previous one, trying to look at lifetime activity and compare that to the presence of CAC. Or here, we're looking at, yes, the prevalence of any CAC score over 0. So on top, we have the fairly inactive group only doing 3.75 met hours per week. And all the way on bottom, we go up to 22 and over met hours per week. And just like before, you'll start to notice a pattern here. We see great benefit in CAC protection with those who perform any activity. However, there's no stepwise decrease in saying that the more active you are, it doesn't give you more protection from CAC. So we have, once again, suggestion of either J-shaped curve or at least a flattening of the benefit the more active you get. Looked at another way, this study is from the Mayo Clinic, looking at fitness and associating that with CAC scores. So here, investigators looked at about 3,000 people who've had stress tests and categorized them into a fitness category. A little confusing, but this is functional aerobic capacity based on a percentage of your predicted VO2 max. So if you look at someone that's 100% predicted, they are doing at least their predicted aerobic capacity. 130, they're doing more than that. And then these categories below, they're less fit than they're predicted to be based on their age. So here we see a decrease in CAC scores across ages, in that once you hit your 100% predicted fitness, you seem to have the lowest CAC score. But now, in those who are more fit or can do over 130% of their predicted VO2, we see at least a numerical increase in their CAC scores, suggesting once again that in those who are the most fit, we'll say here, there may be an increased predisposition toward developing CAC or toward the prevalence of CAC. Which brings us to here, a classic study by Molenkamp and colleagues in sports cardiology. So here, this is a German study looking at 108 recreational male marathoners over 50 years old and comparing them to matched controls here. The main finding here is that the marathoners had increased CAC scores. They had a mean CAC score of 36 compared to Framingham risk matched controls who had a CAC score of 12. This is quite a novel finding at the time. However, looking at the studies, while this was a remarkable finding, the male marathoners, despite being healthy enough to perform all these marathons, still had coronary risk factors. So that's something to always keep an eye out on in athletes. Now here's a follow-up study from a different group in Europe several years later. This one tried to investigate further the association between exercise and CAC, specifically in recreational and competitive older athletes. So here, investigators looked at 284 male athletes, all over 45 years old. As described previously, CAC was highly prevalent in over 53% of individuals, and the mean CAC score was 36 Agatston units. Interestingly, very intense exercise, over 9 METs, was independently associated with both the presence of coronary calcium as well as the presence of coronary plaques. So this study was interesting in that all athletes had coronary CTA, and here is kind of one of the main figures looking at plaque characteristics in these athletes. So panel A shows the CAC score. One of the main things to look at here is that the white columns within there have a CAC score of 0, and you see that CAC score of 0 goes, the prevalence of a CAC of 0 goes down the more active you are. So and then the prevalence of a CAC score over 100 seems to be more in those who are most active compared to those who are less active, suggesting once again that in let's put it this way, the runners with the most lifelong exercise volume had A, more CAC, and B, more high CAC scores over 100. And in figure B there, that is the prevalence of any plaque in these athletes stratified by exercise group. And once again, we see that those athletes who have the most lifelong exercise volume have the most plaque, period. But investigators further broke down what kind of plaque types were present in these exercise groups. And we see here in the left panel that mixed plaque was least prevalent in those who did over 2,000 MET minutes per week. And as we all know, those mixed plaques are the ones that are thought to be higher risk for causing acute coronary events. So at least based on this data, those who do the most activity have the least of that high risk plaque. And look at the dominant plaque physiology, this left panel here in the second table, figure B, we see that calcified plaques are the most dominant plaque in those who are the most active, performing over 2,000 MET minutes per week, which suggests at least that those who are the most active, yes, they have more plaques, but these are predominantly calcified plaques, which taken further, some suggest may explain that increase in longevity for endurance athletes despite increased coronary calcium. So here's a follow-up to that study. This was just published ahead of print just last week or the week before that. So here the same investigators looked at that same population and tried to determine what exactly was associated with any progression in CAC among these runners. Main finding here, if we look at these red bars and these whisker plots here, is that those who performed very vigorous activity are the ones who tended to have that increase or that progression in their CAC score. Now, and looking at these yellow bars, which is those who did vigorous activity, now it seems to be that those who did vigorous activity had less progression in CAC, and those who did the most vigorous activity, what we call very vigorous activity, had some progression in plaque, suggesting that at least over 6 years of follow-up, that it was very vigorous activity that encourages plaque progression. And actually, the surprising thing is that the volume of exercise was not related to the change in CAC. Now, just laying out some definitions here, they define very vigorous activity as over 9 mets, vigorous activity as 6 to 9 mets, and moderate as under 6. So here, last study I'll show in this area. This is from the group out of Dallas here, looking at CAC and how that associates to mortality in otherwise a low-risk population. So as the previous, they've also identified the association between physical activity volume and CAC scores. And those who are more active have a higher risk of having a CAC score over 100. This study was interesting because they were able to derive mortality incidences in a very large population here. And here, subjects were split by the presence of a CAC score under 100 or the presence of CAC over 100. And we see here, look at these highlighted boxes, that exercise volume seemed to be protective, at least when stratified by CAC scores. So those with less CAC, those who did more exercise had a decreased mortality. And those with the CAC over 100, once again, the more exercise you do, the lower the mortality we observe in these populations. So while exercise, while exercise may give some protection from mortality in those with CAC, we still have to note that the absolute incidences of mortality within these subgroups is much higher in those with a CAC score over 100, saying that as with the general population, while exercise is protective, the presence of a high CAC score still indicates a higher risk of mortality than those with less CAC. So takeaways on this topic here are that high levels of physical activity are associated with what appears to be accelerated coronary artery calcification. Athletes may have more plaques, but these plaques are predominantly highly calcified and therefore may be more stable. The presence of CAC in athletes still indicates cardiovascular risk, just as it does in the general population. And one caveat here to all these studies I just talked about is that these studies were all done in almost entirely male populations. So we still need data in female athletes to see whether or not this holds true. Okay, jumping to the next topic here. I'll be looking at cyclists with atrial fibrillation. So here, similar endurance athlete, he's 42 years old. He races competitively in his age group. He's been training for 20 years and rides 200 to 300 miles a week. For the last year, he's been noticing he's been having episodes of several minutes of palpitations, no other associated symptoms. They can occur while riding, but they can also occur not while riding, and they happen roughly weekly. He comes to clinic for that. His physical exam is otherwise relatively unremarkable. He does have an irregular heart rate, but normal blood pressure and BMI. He's got no medical history. On his EKG, though, it does show that he's got rate-controlled atrial fibrillation. And then his blood work shows no diabetes and a healthy LDL of 70. So our rhetorical question for this patient is, which of the following is or are true about atrial fibrillation and exercise? A, intense exercise is associated with AFib. B, low and moderate intensity exercise are associated with AFib. C, high vagal tone may encourage AFib in athletes. Or D, atrial remodeling and enlargement are common in athletes. So once again, keep those questions and answers in mind as we go through the data here. Okay, so first study I'll be talking about here looks at non-athletes. However, it's trying to identify associations between fib and exercise in the form of walking in older individuals. So here, investigators looked at 5,400 people over 65 years old, queried them on how much they walked, and identified a risk of new or incident AFib over a certain time period. And here, the main figure here, we see that based on quartiles of walking volume, that there is a decrease in incident AFib the more one walks. However, when you look at their exercise intensity in particular, we see similar pattern to what we saw with CAC, in that yes, any exercise seems to offer some protection from the development of AFib, but there's no dose-dependent relationship, in that those who perform the highest intensity exercise seem to have roughly the same protection from AFib as those who perform low and moderate intensity exercise. But in fact, if you look at some of the confidence intervals here and you squint real hard, you can see that maybe there's an increase in AFib in those who perform the highest intensity exercise. So looking at those who perform the highest intensity exercise, on that far right side of exercise, we have endurance athletes. So when we're talking about U-shaped curve, we have on the left side, high-risk AFib is those who do no activity. And on the right side, perhaps, we have those who do the most activity, which is athletes. So this here is a meta-analysis of studies, mainly out of Europe, looking at incident atrial fibrillation in athlete populations. And this study found that actually the odds ratio for developing fib in athletes versus non-athletes is 5.29. So it's an interesting finding, and sees the athletes do have an increased incidence of atrial fibrillation when compared to non-athletes. However, once again, this is almost entirely male populations. So that is where most of this data comes from. Perhaps this association between high levels of activity and incident fib is best illustrated in this study here, another landmark study in sports cardiology by Anderson and colleagues, looking at this long distance cross country Swedish ski race called the Vasaloppet race. This is a 55-mile cross country race, skiing cross country race that occurs every year. And there are many athletes that participate, and many of them participate in multiple events over the years. So here, athletes were followed longitudinally with rhythm monitoring to see which athletes developed new arrhythmias over this 10-year follow-up. So here the data is presenting arrhythmias period, but those arrhythmias were predominantly atrial fibrillation. So main finding here is that if you look at athletes by finishing time group, that is how fast they finished, those athletes who were the fastest, who had closest to the 100% of the finishing time or the winner's time, had an increased hazard ratio for developing arrhythmias, mostly AFib. So put another way, the fastest athletes developed the most AFib. And also looking at the number of races, those athletes who did the most races, particularly those who did over 5 or even those who did over 3 or 4, had more incident atrial fibrillation than those athletes who just did one event. So rephrased here, if you extrapolate here, by finishing time, the faster athletes, perhaps those who do the most intense exercise, have more incident atrial fibrillation. And then those who do the most races, which you can extrapolate as those who have the highest volume, also develop more atrial fibrillation than those who have lower volume and lower exercise intensity. So while we see that athletes have more AFib, and it might be associated with volume and intensity of exercise, one of the main questions that's been trying to be answered is what exactly is the mechanism behind this? Now, going all the way back to the 90s, it's been noted that athletes have larger left atria than non-athletes, and it's been thought that this is one of the main contributors to AFib. Now here we have an interesting study kind of trying to look at that here. This study was published in Circulation 3 years back out of the study group at UT Southwestern. This is an interesting study in that it was an interventional study where they took sedentary adults split the group into two and put half of them on a high intensity exercise regimen for 2 years, and then measured their atrial volume as well as atrial activities to see what happens when you go from essentially sedentary to a frequent high intensity exerciser. So here, looking at the main figure results, left side here is index left atrial volume. And we see at the halfway mark, that's 1 year, there was an increase in left atrial volumes, but it was a small increase. However, at the 2-year mark, at the end of the post-study period, there was definitely a noticeable increase in left atrial size. However, this raw left atrial size did not quite come to that level that we see in athletes, which we have here. But looking at cardiac remodeling in endurance athletes, we know that exercisers have both enlarged LVs and left atriums. But it's the thought that those who have predominantly larger left atriums may be at higher risk for atrial fibrillation. So here in this graph here, we have results kind of the same way as previous, but looking at the left atrium, left volume, left ventricle ratio. And we see that once again, at the midway mark, there was no significant increase in LA to LV ratio, but at that 2nd year mark, end of the study, there was a great increase in the LA to LV ratio. And actually this ratio approximated the same ratio that we see in athletes. So after 2 years of exercise, yes, atria get bigger, and B, it seems the left atria get larger than the left ventricles, at least relationship-wise. Now this is put in parallel against EKG data, which I don't show here, but long story short is that the EKGs didn't show any electrical remodeling, and that there were no P-wave changes, P-wave duration changes. And there were multiple measures of root mean square voltages, looking to see if there's any electrical remodeling, electrical changes in the atria, and there were none. So summing this up here, at least starting people on 2 years of high intensity exercise, atria grow, but there are no EKG changes signaling electrical changes in the atria. So at least with the development of AFib, if anything, this mechanical remodeling seems to precede electrical remodeling. So speaking of electrical modifications here, there are a few proposed mechanisms to which exercise may predispose one to AFib. And the first one is the one that we see in clinic all the time, is that these athletes do have dramatically increased vagal tone. They're coming in frequently with dramatic resting bradycardia. And this, in theory, may promote atrial fibrillation. Now, looking at some more animal models, there have been models exercising rats, and it's been shown that these rats develop AFib with that high amount of exercise. And this AFib is associated with high levels of atrial fibrosis. So is there some degree of atrial fibrosis that happens in exercisers? Maybe, at least there is in animals. Basic studies have also shown that there are funny channel alterations with exercise. And when you remove autonomic tone, and this is actually in people, they can measure conduction times, and these conduction times are globally slowed despite the removal in vagal tone. So all this points to, yes, there is some electrical remodeling that probably happens that may predispose exercisers to atrial fibrillation. But of course, the mechanisms here, especially in humans, still have to be worked out. So next we go to management of fib. Long story short, it can be very challenging in endurance athletes. There are no strong recommendations here, but the ESC says that you can try 2 months of D training, as this has been shown in some studies to decrease AFib. However, anyone taking care of athletes knows that recommending two months off of exercise frequently is just not a viable option. Other considerations that need to be taken for this population are performance impairment, specifically endurance activity performance impairment, and that any therapy we give should minimally affect physical performance, as that is kind of one of the key measures that these recreational athletes live by. And also, in those who we are prescribing anticoagulation to, that comes with risks. And while endurance athletes don't generally engage in much contact, cyclists, for example, can get in traumatic accidents. So that has to be taken into account when prescribing anticoagulation. The other thing is all the recommendations that exist are done off expert opinion. There are data in these populations, but it's not large, robust data as we have in AFib general population studies. Now, I want to highlight one of the main recommendations here. Once again, this is the 1C recommendation. That is, athletes with low risk AFib that is well tolerated and self-terminating may participate in all competitive sports without therapy. Saying that in those athletes who don't have any malignant features of the atrial fibrillation, we need to be careful not to be recommending exercise restriction just because AFib is present. Now, here are some of the AFib management options. Now, just like in general population, we have rate control, rhythm control. Rate control is often not viable, unfortunately, in athletes. Number one, due to resting bradycardia that we see. At least I'm always hesitant to start someone with a resting heart rate under 50 on too much rate control. And then at least anecdotally, beta blockers are very poorly tolerated by all athletes, in that most athletes either get fatigued or notice performance impairments when they start a beta blocker. So this is often not a realistic option for them. Now, with regard to rhythm control, the pill and pocket flecainide approach for those who have less frequent AFib is popular and it's effective in endurance athletes. However, in those who perform long or intense events, there are electrolyte swings, which raise concern that we may promote arrhythmias in those who are given flecainide to. And if you actually look at the European recommendations, they recommend waiting 2 half-lives of flecainide before engaging in intense activity, which effectively rules out that rapid pill and pocket approach. Which brings us to ablation. Now, there are no large-scale studies looking at ablation in endurance athletes, but there are several good, decent quality small studies showing that, at least in these studies, that the success of AFib ablation is similar in athletes and non-athletes. However, one thing to tell them when you send them for ablation is that their resting heart rate and exercise heart rates can change sometimes for whatever reason following that ablation. Now, while we don't generally go straight to ablation in the general population, when you look at athletes, if rate control isn't well tolerated, rhythm control doesn't work, frequently athletes may be at least wanting to discuss ablation to see if this is a reasonable option for them. So summing up key points here in this population. Number one, intense exercise is associated with incident atrial fibrillation, and this is predominantly intense endurance exercise. Number two, AFib is common. It can be difficult to medically manage in athletes. We may prefer rhythm control or ablation up front, but once again, this is all shared decision-making and case-by-case basis. And as with CAC, we need to be careful not to discourage people from exercise, as this increased AFib at higher levels is really only seen in these dedicated endurance athletes. It does not apply to the general population. Okay, last topic here. I'll be talking about an endurance athlete with a dilated aorta. So here, similar patient to the last one. This is the 50-year-old male road cyclist. He's been riding and racing for 30 years, and is competitive in his age group locally. He rides 200 to 300 miles a week. Now, he also got a commercial CAC scan, which didn't show any coronary calcium, but did note an aortic aneurysm. So he promptly made an appointment with a cardiologist to address that. Now, he has no past medical history. He's not on any meds. His physical exam is also unremarkable. Normal heart rate, normal blood pressure, normal BMI. We first started with an echo on him. And the main finding there was we identified an aortic root diameter of 4.2 centimeters with an otherwise normal tricuspid aortic valve without any significant regurgitation. We also asked him about his family history, and he has no sudden deaths in the family and no concerning features or no concerning family features for either connective tissue disease or thoracic aortic aneurysm syndromes. So the main question for him, which is what he's coming in with, is, does this athlete have pathologic aortic dilatation? And I'm going to try to answer that in the next few slides here. So backing up to aortic dilatation in general, not just in athletes, the aorta is considered dilated once you get over, generally speaking, once we get over 4 centimeters, and aneurysmal once we get over 4.5 centimeters. And this is due to the rate of aortic events we see at these diameters. So here, assuming a normal aorta is over 3.4, is under 3.4, sorry, we have a slight increase in dissections once we get over that. And once we hit a diameter of 4, we have an even further increase in aortic events. But over 4.5 is when we really get this astronomical increase in aortic dissections. So the numbers to remember here are 4 at 4.5 for when we start worrying specifically about dilated aortas and aortic dissections. So the most prominent risk factors for aneurysmal growth as well as dilation are, number one, obviously, the hereditary or genetic issues. Do these patients have syndromes or connective tissue disorders that may predispose them to aortic dissection? And then also commonly, do they have bicuspid valves, which, as we all know, have accelerated growth of the aortic roots? And in addition to those very well-established factors, our garden variety cardiovascular risk factors are also associated with aortic growth. That includes hypertension, atherosclerosis, diabetes, and smoking. And the question we're trying to address here is exercise a risk factor for aortic growth as well? Now, this issue of aortas and exercise has been addressed in the past. This here is the largest study. It's a meta-analysis looking at aortic sizes in athletes compared to non-athletes. And here, investigators looked at 5,000 elite athletes and compared them to non-athlete controls. Now, keeping in mind here, this is cross-sectional data, and these are younger athletes, mean age 15 to 40. The main finding here was the athletes had a 3 millimeter larger aortic root than non-athletes. However, at least in this younger population, the mean aortic root diameter was still just 33 millimeters. So that's well within the normal range. So these investigators stated it as such. They said that yes, athletes had statistically significantly larger aortas than non-athletes. However, this growth did not approach clinical significance. Now, here's a recent study looking specifically at masters endurance athletes and their aortas. Now, this is out of the group at MGH, just published in 2019, actually. So they looked at 440 runners and rowers aged 50 to 75 and evaluated their aortas. The main finding here was pretty striking in that 21% of these athletes had an ascending aorta over 40 millimeters. And even after correcting for body size and Z-scores, that a quarter of them has Z-scores over 2. So that's a very, very high rate of what's considered an abnormal aortic size in these otherwise healthy athletes. Looking at this data further, looking at specifically these 21% of people who had dilated aortas, here's the main figures showing the distribution of aortic size depending on sport and gender. And we see here on the left side, the measurement of the aorta at the sinus of Valsalva. We see this bell curve here. It's important to note, though, that in the middle of this graph is an aorta of 40 millimeters. So clearly, the distribution of the aortic size is shifted to the right, with many athletes over 40 millimeters. And looking by sport, specifically in rowers, we see that here's a predicted sizes in the blue, and then actual size in the green. We see a very obvious rightward shift and rightward tail on these athletes. There are many athletes over 40 millimeters, and some of them up even past 45. So while this study identified high prevalence of dilated aortas in endurance athletes, the question still remains, number one, is it pathologic? And number two, does this lead to poor outcomes? Here's a study we published, small preliminary study just recently, trying to at least address some of these questions. So we looked at 59 low cardiovascular risk runners, put them all on an exercise test, exercised them to their maximum, and then also echoed them to see what their aortic roots look like. And similar to the previous Churchill data, we found that about a fifth of them had aortic roots over 40 millimeters. And when we analyzed it further, we found that this aortic root size was actually associated to the exercise blood pressure augmentation, or specifically the difference between their maximum blood pressure and their resting blood pressure. So we identified this. It was a novel association between exercise blood pressure and aortic size. But the next question was, okay, so exercise blood pressure associates with aortic root sizes. What does that mean? Now, we don't have definitive answers there, but we did try to address this by splitting these athletes into those with aortas under 40 and aortas over 40, and seeing how the rest of their cardiac remodeling looked. Main things were here that there was an increase in LV mass with large aortas. However, this was all with the relative wall thickness in the normal range, and there was no difference there. Now, endurance activity leads to eccentric LVH, which is what we see in both these populations here. We have no concentric remodeling patterns. We have also no differences in diastolic function or arterial stiffness, showing that yes, some of these athletes do have large aortas, but at least when looking at the rest of the heart, we don't see any other signs of pathologic remodeling. So at least in this study, these large aortas were associated with blood pressure, but not associated with any other signs of maladaptive cardiac remodeling. So trying to answer that question, does this athlete have pathologic aortic dilatation? And the answer is maybe. I would say probably not. Yes, the aorta is large, it's over 40. However, all the data we have so far show that these large aortas do not associate with other signs of cardiac dysfunction. Now, of course, the caveat here is that this patient does not have any aortic syndrome or connective tissue disorder, so it's important to get genetic studies on this patient. Another thing that we're really waiting for is we don't have any longitudinal aortic outcome studies in these athletes. In that, do these athletes suffer from higher incidence of aortic events? And really, that's the key picture here, the key question here, and we need to determine whether or not this is pathologic or not. And lastly, at least based on our preliminary data, it seems that this aortic growth may be related to chronic volume challenges, which lead to blood pressure changes with endurance exercise. But of course, all this needs further investigation. So summing up here for our 3 cases, key points here are as follows. With regard to accelerated coronary calcium, athletes with coronary calcium are at lower risk than non-athletes with coronary calcium. However, the presence of CAC still does indicate some risk. And these findings are mainly in male athletes. So I guess the key phrase here would be that male endurance athletes do have a higher incidence of coronary calcium. And with regard to AFib, AFib is about 5 times more common in athletes than non-athletes. However, it can be difficult to treat as this athlete substrate limits our typical treatment option. And with regard to aortic dilatation, this is present in a remarkable 20% of middle-aged endurance athletes. But we really need longitudinal studies to see what this means. That concludes my talk here. I obviously have to thank Dr. Jonathan Kim for allowing me to follow him around the clinic for the last few years and kind of gain this experience that I had and really develop this interest here. And then with that, I'll take any questions.
Thank you, Jason. Very good. Interesting review and sort of timely topic. I mean, not particularly related to recent events in the world of sports, but tangentially related. So, question regarding aortas in these patients, and you may have said this. I think I was on the phone briefly while you were talking about aortas. What do you think about medication, sort of even for normotensive patients with enlarged aortas, be it beta blockers or ARBs, ACE, et cetera, for these patients? And if you said this already, I'm sorry.
I did not say that, but I think case-by-case basis, a lot of athletes don't want to take any medicines, period. But when you say the word aortic aneurysm, sometimes that changes. I think it's reasonable at least to talk to them about starting an ARB plus minus a beta blocker, given the data, at least with people with connective tissue disorders and aortic growth. I don't think we necessarily have to mandate it, but it's not a bad idea if they're willing.
Yeah, I mean, I'll just say the data is weak. I mean, there's clearly no data in athletes, and even the data for patients with connective tissue, normotensive patients with connective tissue, is not terribly strong. It's it makes more mechanistic strength, and it sort of varies a little bit from study to study, but still, at least you feel like you're doing something for the patient. Yeah. So.
Hey guys, so
Other questions?
this is John. Can you guys hear me? This is Jonathan.
Yep.
Yeah. Hey, so first off, yeah, really nice review, Jason. I just had a couple comments, really not a question, but for those still on, I think one of the things that's really important to take away after a talk like this is, regardless of whatever potential pathology or maladaptive change that you talk about, people who exercise even at extremely high levels do better than everyone else. And you mentioned that, but it's an important point. The point about the J-shaped curve is important for people to remember that in the Copenhagen heart study, that J shape was based off of 2 people who died. So if you really look at the hazard ratio, it's unbelievable. That study got published in JACC, to be quite honest. So and it's not disclosed what those 2 people died of. They could have died from motor vehicle accidents, so it's not clear that they even died from heart disease. As it relates to CAC, I think that it's really primarily driven by early traditional risk. In my experience, anybody that I've ever taken care of, even for those who have the random kind of CAC anecdote that you presented, you'll generally find something, whether it's family history or hypertension or something that probably is driving it more so than the exercise. So there is this association for some who have minimal traditional risk where there is some, at least appears maybe some increased risk of CAC, but it's important to remember as you counsel these patients, and I'd encourage anyone to really involve here, of course, our group, but wherever you may be, the person who likes to take care of or has experience taking care of athletes, that if you look at the Defina and Ben Levine's work, those who continue to engage in high intensity exercise don't do worse. So there's no increased cardiac outcome. So the worst thing you can do to tell them is to stop running, because that really kind of shows that you don't quite appreciate why they like to do this, because it's beyond much more than health benefits. So that's important to remember. Of course, it is important to remember that any CAC is bad CAC. So you just have to really kind of go through that thorough search. And then the last point I'll make as it relates to aortic dilatation is while there are no longitudinal outcomes, I think this really is an adaptive phenomenon. I mean, 1/5 of all endurance athletes have aortas in that mildly enlarged range. And what we know is there's clearly not an increased signal of dissections within this group that's ever been shown, published, or experienced in those who care for this population. And in the study that we published, further evidence would be that what you showed this, but there's a lot more eccentric LVH, which is kind of a more extreme adaptive remodeling form in athletes too. And so I do think there is something about this chronic elevated volume challenge, as we showed with that blood pressure change as well. And Robbie, to your question, I would not put these people unless you're treating hypertension, because just again, you had mentioned the poor kind of data just looking at connective tissue disorders, but in this population, I would actually suggest, in the absence of hypertension, that there's really no reason to suggest putting them on an ARB or a beta blocker.
John,
Go ahead.
hey, go ahead,
Yeah,
sir.
quick question. I wanted to know, you said that the incidence of AFib was 5 times higher. What is the risk of stroke higher in these? And then, given that a lot of the CHA2DS2-VASc score in these people are relatively low, if you're talking about, young people with no risk factors, do you just start them on anticoagulation? Or aspirin, excuse me, aspirin.
So looking at it, so yes, regarding stroke risk, so I didn't present that data, but there is a study out there a few years back showing that yes, athletes can have more AFib, but actually it seems that the stroke risk in these athletes isn't as high as compared to those without. So while I'm sure there's probably some increased stroke risk with FIB, it doesn't seem to directly correlate with the data in non-athletes and elevated stroke risk with FIB. And anticoagulation data, we have to take into account what kind of sport they're doing. So be careful really with full anticoagulation. But with aspirin, generally speaking, it's okay, I think, if they want to take it. Dr. Kim, I don't know if you have any thoughts on aspirin and low risk FIB.
Yes. And then the study you're talking about, Jason, which comes from the same group, the Anderson group, There is definitely lower risk of stroke if you compare it to non-athletes with the same CHADS-VASc score. So you still risk stratify in the same way. So if they have a reason to be anticoagulated, then you follow guideline-based treatment. But the point is, again, is that they still do better than those who don't exercise. But that doesn't necessarily decrease their overall risk of stroke to preclude recommending anticoagulation. As it relates to aspirin, I'd say the same thing. I don't routinely put them on aspirin, similar to as I would approach a low CHADS-VASc in the general population.
Robbie?
Yeah. Go ahead, Steve.
Okay, so like we talked the other day, when you say someone has an aortic aneurysm, that's very scary. And Jason, I like your cutoff point at 4.5, like 4 to 4.5. You probably ought to call that aortic ectasia. If you call it aneurysm, you'll precipitate a lot of consultations, which may or may not be necessary. So, and then measurement of the aortic root, which means the aortic sinus of Valsalva area, sinotubular junction, then ascending aorta. Of course, when the aortic root is dilated, it makes you think about Marfan's, and when the ascending, when it's pear-shaped, it makes you think about Marfan's. And I don't know how you all measure this, whether it's an echo measurement or whether it's a CT measurement. When I go over the CT scans, Patrick, maybe you can answer this question. Do you measure outer edge to outer edge? Because on echo, we measure leading edge to leading edge. And is it 39 or 40? It's not easily measured. So what kind of standards, how did we measure these aortas in your study here, Jason? And
we just used surface echo, transthoracic.
Is that leading edge to leading edge?
Correct, leading edge.
Right. And all of them were echo measurements.
Yes, for this data.
Well, that's certainly correct. Sometimes not real easy to do and can cause confusion. And I like your cutoff point at 4.5. Of course, if you can't figure out what the situation is, and you get an echo in a year and another year and another year, and nothing has changed, then that there's reassurance there, and that maybe we don't have any kind of fibrillin deficiency, anything like that. Very good. Thank you, Jason.
Thank you, Dr. Clemens.
Stan Sherman, Jason. Just one more time with the atrial fib. Basically, let them run if they have the low CHADS-VASc score and don't worry about the atrial fib.
I would say the asymptomatic, yes. That's what our guidelines would recommend as well.
Asymptomatic, but if they notice it, what do you do?
Like I said, you can always try recommending detraining to see if it helps. But overwhelmingly, that's you'll probably get a hard no from the athletes for that. And then we can go down the route of considering rate and rhythm control and see what works. A lot of times it's, like I was saying, it's tough. It's tough with the symptomatic AFib athletes.
If they're symptomatic, I guess they're a little more willing to take medicine.
Yes, at least willing to try maybe.
All right. Well, thanks again, Jason, for an excellent review. And thanks for everyone for tuning in. Everyone have a great holiday weekend, and we'll see everybody next Friday.
The preceding program is copyrighted by Emory University.